Welcome to PGOG postgraduate class in obstetrics and gynecology, and today's topic is pelvic organ prolapse surgery for anterior and posterior compartment defects. Anterior compartment defects are the most common type of pelvic organ prolapse, but failures are more common with this as compared to the other two compartments, which are apical and posterior compartment defects. Compared to that, anterior compartment defects are, though more common, are responsible for recurrence of pelvic organ prolapse. And main reason is sometimes there is associated apical defect which is not corrected simultaneously when we are operating for the repair of anterior compartment defect. And that is why in majority of the cases, whenever we do this anterior compartment defect repair, it needs simultaneous apical repair also. When we do the anterior colporrhaphy or anterior compartment defect repair, it depends on two main points. First is whether we are doing a hysterectomy or not. If we are not doing hysterectomy, then it is called as uterine preservation surgery, where we have to do the hysteropexy. If we are doing hysterectomy and then we are doing repair and apical repair also, especially for apical repair, it will be called as colpopexy in that case. That we have already seen in the previous two videos related to pelvic organ prolapse, and those who have not gone through those videos, for those I request you to go through those videos first so that you will be able to understand various terminologies I will be using while explaining the present video. Now, whenever we do vaginal hysterectomy, which is the common approach for the pelvic organ prolapse surgery, first to do a vaginal hysterectomy, then next step is we do the procedure for the repair of apical defect. Various procedures for the apical defect we have seen already in the last class, where the sutures are taken but these are not tied. Then we do anterior posterior compartment defect repair, and at the end only we tie these apical defect repair sutures so that vagina is lifted up with that. Now, if we want to do the vaginal hysterectomy or patient wants uterine preservation and we want to do only anterior colporrhaphy, then it is done as a step. First step is of anterior colporrhaphy followed by hysteropexy for apical support. So starting point of anterior colporrhaphy is, as this is the usual picture we can see when we start doing the surgery. This is the urethral orifice and indwelling catheter is kept so that throughout the procedure bladder is kept empty. This bulge is anterior bulge over the anterior vaginal wall is a bulge of cystocele, and this is the external os of the cervix. Now, if we want to do only anterior colporrhaphy and we have not done vaginal hysterectomy first, in that case the incision which we take is called as an inverted T incision, where vertical arm is a point below the urethral orifice to the lower end beyond the bulge of the cystocele, and transverse arm is usually 1 to 2 centimeters above the level of external os over the anterior vaginal wall. So this is inverted T incision if we want to do only anterior colporrhaphy where uterus is not removed. If uterus is removed, then first step is we complete the hysterectomy, vaginal hysterectomy, and then we start with the anterior and posterior compartment defect repairs. So for cystocele repair, then we will be giving a vertical incision from a point below the urethral orifice 2 to 3 centimeters below that to the lowermost end of the incision. So that will be only vertical incision if hysterectomy has been done. No hysterectomy, then what the incision which we give is a inverted T incision. First step is how we give the vertical incision. Now this is urethral orifice and this is the proximal end of the midline incision. This is the distal end, such as this is the vertical incision which has been given. So what is important is how to decide the proximal end, where to take the midline incision with respect to urethral orifice, how far we should be from the urethral orifice. Now, proximal end is the place where there is it is at uretrovesical junction. That is junction of the urethra with the bladder. So, how we know where the uretrovesical junction is? Usually, it lies 3 to 4 centimeters below the urethral orifice. But to confirm that, what we can do is we can pull the Foley's catheter so that the bulb of the Foley's catheter remains at the uretrovesical junction, and then we take the point just below the level of the bulb that is going to coincide with the uretrovesical junction. So this is important step to decide the upper limit of this vertical incision. Now once we give the incision, we have to separate the vaginal epithelium or vaginal mucosa flaps from the underlying uh, fibromuscular connective tissue layer of the anterior vaginal wall. And whenever we start with this separation, what happens sometimes is there is a brisk hemorrhage which starts. So in that case, if brisk hemorrhage starts, then it is difficult sometimes to control the bleeding, and that is why dilute vasopressin can be used before giving this vertical incision. 20 units of the vasopressin is added to 50 to 100 ml of normal saline, and then it is instilled at the middle of the at the midline as well as laterally. Step 2 is to do a sharp dissection to separate vaginal mucosa from underlying fibromuscular layer of anterior vaginal wall. So we have to do with the scissor, we have to do the dissection in the correct plane so that only the vaginal epithelium remains separated and underlying fibromuscular layer of the anterior vaginal wall remains intact over the bladder. Now here I want to mention that in the last class only we have seen that vaginal fascia is now called as fibromuscular layer. That is the change of terminology. So previously we used to call it as vaginal fascia. Now it is called as fibromuscular layer of anterior vaginal wall as well as posterior vaginal wall, because it contains not only fibrous tissue but some of the muscle tissue is also present. So this is the separation of this vaginal epithelium from underlying fibromuscular layer of the anterior vaginal wall. Once the separation is complete, then we have to take transverse sutures like that. These sutures are going to lead to the midline plication of the this fibromuscular layer of anterior vaginal wall. Now the literal meaning of the word plication is folding. So here we are folding the fibromuscular layer upon itself so that it forms a strong support at the midline. That is why it is called as a midline plication. Once the midline plication is over, then we have to cut excess vagina. Now what is happening in cystocele is bladder is protruding to the defect in the fibromuscular layer of anterior vaginal wall. And with that, what is happening with increasing size of the cystocele over the years is there is stretching of the vagina also. Anterior vaginal wall also elongates and becomes broad also. So we need to cut the excess of the lateral vagina, anterior vaginal wall at the both lateral sides. Then we have to suture the anterior vaginal wall by either interrupted sutures or we can take a locking continuous suture also. Now cystoscopy is advisable and it should be done at the end of this anterior corporaphy, mainly to rule out any bladder injury or sutures being taken through the bladder mucosa, as well as to confirm the patency of ureters. Now, sometimes what happens is this cystocele is associated, is in majority of the cases, it is a central defect, central cystocele. But sometimes it is associated with a lateral defect also, where there is a absence of lateral vaginal sulcus. Now this lateral defect is because the this level 2, that is the arcus tendinous fascia pelvis, which is supporting the middle one-third of the vagina. It is getting detached from this fibromuscular layer of anterior vaginal wall, and that leads to the development of this lateral defect, leading to the cystocele, which is either present in the midline as well as laterally on one or the both the sides, or sometimes only a laterally placed cystocele is seen. If we diagnose that there is a presence of a lateral cystocele, then what we have to anchor is, we need to anchor this arcus tendinous fascia pelvis with fibromuscular layer of anterior vagina, and lastly the suture passes through vaginal epithelium. So through these three structures the sutures will pass. Number of sutures depends on the how much is the defect. 3 to 6 sutures are taken. What needs to be done and why technically it is a challenging procedure is, when we separate the vaginal epithelium from underlying fibromuscular connective tissue layer of the anterior vaginal wall, we need to go too laterally. We need to do the blunt dissection with the finger till we can palpate ischial spine. Then only we can identify this arcus tendinous fascia pelvis, which is passing from ischial spine to the pubic symphysis just lateral to the midline. It is a tough, strong, fibrous structure, and it is also called as a white line, which is running from the pubic symphysis to the ischial spines. And to approach this arcus tendinous fascia pelvis, we need to do too much of a lateral dissection. Blunt dissection is usually required, but sometimes it leads to brisk hemorrhage, and that is why one of the complications of this procedure is excessive bleeding or hemorrhage. And it is given that around 25% of the patients need blood transfusion because of this excessive bleeding. In that sense, it is technically somewhat challenging procedure. Now, what is the current status of use of mesh in vaginal pelvic organ prolapse surgeries? Mesh was used to reinforce the weakened supports, and it was called as graft augmentation also. So that means we are plicating the fibromuscular tissue of the anterior vaginal wall. With that, additional enforcement is done with the by using the synthetic material, that is mesh. But FDA in 2008 issued a warning against the use of vaginal mesh, especially for the vaginal surgeries of pelvic organ prolapse, because what was seen was there was a high risk of mesh exposure or mesh erosion, leading to dyspareunia, persistent vaginal discharge, or pelvic pain, lower abdominal pain, which required sometimes even repeat surgery also. In 2011, FDA advised all the companies to do the post-market surveillance if they wanted to keep on producing the mesh. With that, many companies stopped producing mesh, and overall the popularity of the mesh used especially for anterior corporate popularity went down with that. Present opinion is there is no definite benefit of mesh use as compared to the anterior corporaphy, which is done with the uh, traditional method, and that is why the mesh use is less popular. Now, I want students to understand that if you are asked about the mesh, or you are even theory paper you are writing about pelvic organ prolapse surgeries, this much you should be able to say. The only indication of the use of mesh without any doubt, which is beneficial at present for the surgeries of pelvic organ prolapse, is for abdominal sacrocolpopexy or abdominal sacrohysteropexy procedure, but not for the vaginal procedures. Now we come to posterior compartment defect surgery. Two ways posterior compartment defects can be repaired. One is traditional posterior colporrhaphy, which is also called as midline plication, which is done exactly same as we do for the cystocele repair. Or second, which is a newer, comparatively a newer method, is site-specific posterior repair. Now, both of these procedures, this can be done along with perineuraphy if required. So, if required, the perineuraphy can be done along with any of these two ways of doing the posterior repair. In perineuraphy, what we want to do is we want to increase the length of perineal body and we want to reduce the dimension of genital hiatus. Genital hiatus is from mid-urethral point to the foreshead, whereas perineal body is from foreshead to mid-anal orifice point. And with the level 3 defects, what happens is there is a reduction in perineal body length and increase in genital hiatus. So by perineuraphy, we want to correct that. Along with, we want to do the correction of the perineal body reconstruction also we want to do by approximating the muscles contributing to the development of perineal body. Again, for this also posterior compartment defect, we can use vasopressin diluted 20 units in 50 to 100 ml of normal saline, and it can be infiltrated, which will reduce the blood loss while separation of vaginal mucosa away from underlying fibromuscular connective tissue layer of the posterior vagina. Now, this is how we do the perineuraphy. This is the vaginal orifice, and we apply two Ellis tissue forceps and approximate and see that vaginal orifice admits at least 2 to 3 finger blades. That is how we decide where to apply the Ellis tissue forceps and how much is to be repair of the perineal body to be done. Then we give incision, remove that much of vaginal mucosa. Angular flap is removed and suturing is done so that the perineal body which was shortened will be going back to normal length with reduction in the length of genital hiatus. Now, this is important. What I want students to remember is it is not only this cosmetic correction of perineal body and genital hiatus which we do by perineuraphy. We also strengthen or reconstruct perineal body by taking these lateral stitches at 4 o'clock and 8 o'clock position. These lateral stitches are taken and these are approximated, tied with each other so that there is approximation of perineal body muscles. Perineal body muscles are superficial transverse perineal muscle, deep transverse perineal muscle, and bulbocavernous muscle. These muscles are approximated in the center that leads to reconstruction of perineal body. Now for traditional posterior pulporrhaphy or midline plication, again like cystosil, we have to give a midline incision. This proximal end is beyond the level of the bulge and distal end is either at the incision where perineuraphy has been done or it can be done, it can be at the junction of the vagina with the skin. Vaginal mucosa with the skin. This is the vertical incision and then we do the separation of the vaginal mucosa from same way from the underlying fibromuscular connective tissue layer of the posterior vagina. Once the lateral dissection is done, then transverse sutures are taken same way as for the cystosil. This is traditional posterior pulporrhaphy. So step 2 is midline plication, plicating the fibromuscular layer so that suture line will be in the midline. Second technique is called as site-specific posterior repair. Here, same vertical incision is given, separation of the vaginal epithelium from underlying fibromuscular layer is done in a similar manner, but rather than plicating the fibromuscular layer in the midline by taking multiple transverse sutures, what is here done is we do a PR examination and with the finger we see where the weakness in fibromuscular layer is. Here as you can see in this patient, here is an oblique defect in the fibromuscular layer and here is a transverse defect where the fibromuscular layer is detached from the perineal body. This is the site of perineuraphy. So we will be taking some sutures here and we will be taking 1 or 2 sutures there. Number of sutures is less This will be the final picture. Site specific. Why it is site specific? We are identifying the weak site by doing a per rectal examination, and only at that site only we are suturing the fibromuscular layer of posterior vaginal wall. Advantages, there is less vaginal narrowing. Now, whenever we take multiple sutures post-operatively, there is a formation of fibrosis, and that with midline plication, there is more of a vaginal narrowing after a few months after doing the posterior colporrhaphy by traditional method. Here, less vaginal narrowing and less dyspareunia is there. That is the advantage of doing this site-specific posterior repair. Here we have placated the fibromuscular layer with perineal body because it is a transverse defect at the lower end, separating fibromuscular layer away from perineal body muscles. Now, PR examination is mandatory whether we do this posterior repair by midline plication or site-specific posterior repair to ensure that rectal mucosa is intact, no suture has gone through the rectal mucosa. Now, apical compartment repair is usually required whenever we do the anterior compartment repair. I have already told you that. And this apical compartment repair has been covered in detail in the previous video. In short, what is done, vaginal procedures are Mackal scutoplasty, which is usually done as a colpopexy, or here post-hysterectomy, we are plicating the uterosacral ligaments in center and we are closing the cul-de-sac. That is why it is called as cultoplasty. Or we can do uterosacral ligament suspension or sacrospinous ligament fixation. With both these procedures, there is a choice. We can either do colpopexy, that is first do hysterectomy and then lift up the vagina by attaching the vagina to either uterosacral ligament or sacrospinous ligament. Or we can do hysteropexy where uterine conservation is done and uterus and the cervix is anchored either with uterosacral ligament or sacrospinous ligament. Only one abdominal procedure is there, that is abdominal sacrocolpopexy, where with the help of mesh we are attaching one end of mesh to the anterior longitudinal sacral ligament just below the level of sacral promontory, and other end is attached to the anterior and posterior vaginal wall. Can we do the anterior posterior compartment defect repair abdominally? Yes. When we do abdominal sacrocolpopexy, usually it takes care of small to moderate size cystosis. There is no need of doing additional colporrhaphy. But if it is a large defect, then we have to do anterior colporrhaphy along with abdominal sacrocolpopexy. Now, this abdominal sacrocolpoperineopexy is done, that is attaching the mesh to sacral ligament, anterior sacral ligament, also to the vagina, anterior and posterior wall, and also it is attached to perineal body. Now, this procedure is done whenever there is a level 3 posterior defect, where the perineal membrane defect is the possibility, as patient has got defecation problems where she cannot defecate unless she does the splinting. That suggests that there is a perineal membrane defect where the mesh is attached to perineal body also. Now, for students, one request is practice drawing line diagrams. It helps us to understand the topic in a better way, as well as it will help you whenever you will be writing the theory papers. And most important is enjoy the study time. Thank you so much.